Welcome to the Modern Patient Experience, a show about how U.S. healthcare is adapting to new patient expectations. I'm James Furbush, Director of Marketing at Access One, a company that empowers revenue cycle teams to help all patients effortlessly pay for care in full or over time. In each episode of this show, I interview executives from hospitals and health systems, physicians and nurse leaders, digital health pioneers, and others to better understand what it means to be truly patient-centric. The goal is to serve up new ideas, frameworks, and tactics that will help your organization give your patients the best clinical, financial, and operational experience. And away we go. Hi, welcome to this week's episode of the Modern Patient Experience. I'm your host, James Furbush. My guest this week is, I'm very excited, it's Rick Toren. He's the CEO of SwiftSync. He has had a long and illustrious career, best known for inventing the Epipen, the Holter monitor. He has started several companies, including eMedics and CodeWrite. He is a board member of the AHA and Christiana Health System. Rick, welcome to the show. I'm so happy to have you on.
Pleasure to be here.
And so, Rick, I usually like to ask my guests to start off how they like to recharge their batteries. We can talk about that, but it feels maybe the better question is, do you ever get a chance to sleep? It feels like you have a lot going on between SwiftSync, teaching classes at the University of Miami. And, I'd love to hear how you recharge your batteries or find time to not suffer from burnout.
Good question. First of all, I make sure I get 7.5 hours of sleep every night. Without that,
so you do sleep. Okay.
Oh yeah. I'm dogmatic about it. So I'll get to sleep at 9:30 and I'm up at 5:30, 6 o'clock every day. But I do get to play. I play tennis. I make sure there's nothing in my schedule before 10 a.m. because I play every day from 8:30 to 10. And I think having physical exercise is an important way to recharge and keep yourself sharp. As you can tell, I'm not 45 years old. I've been at this for many years, and I don't feel like slowing down is in the future. I thought I would retire, but I just can't imagine that. It seems like it would be hard to keep active once you think of retiring. So I don't have any problem thinking about recharging. It happens.
Yeah, that's awesome. So I love it. So physical activity, 2 hours tennis a day. I got little kids. I try to get a run in. That's my thing, is going for a good long run to start my day. Doesn't always happen, but the days when it does happen, I feel like are typically the better days that I typically have. So if you're starting your day at 10, then, are you working like later into the night? What does that sort of look like for you? I'm just curious about that.
Oh no, I would say I work from 10 to 4, 6 hours, but I'm on the internet after that until the moment I go to sleep. So I don't know if you count that as work. Probably is, because I'm talking to different companies and I'm on 6 boards, and that keeps me active and working on a board and committees of the health system and all the challenges that we have, continue to have with healthcare. So I feel like I'm an active contributor. And once you think you're contributing, it sucks you in because you feel like you get this inflated ego, like they can't do without you. So you put a lot of time and effort in it because you really want to improve not just the patient experience, but right now, to give you an example, our health system is 6 hospitals, and we do about $2.5 billion a year in revenue, but we're short of 2,200 employees right now.
Okay.
So that's a real challenge. How do you keep everybody else working hard and taking care of all the patients? And you really, as a board, it's one of your jobs to make sure the line workers are motivated and to take care of people. So that's a challenge.
Yeah, this is fascinating. The employee shortages, it's just similar to what other industries are going through recently. Obviously, we heard about the great resignation or whatever it is, but just these sort of last couple of years, finding enough workers has been a challenge for a lot of companies. Is that sort of systemic for the companies that you're on? Is there something else that's going on, or what's kind of at the cause of that?
COVID had a lot to do with it because we ended up burning out a lot of nurses because they're working many hours because you had to find people who were willing to work, get exposed, even though you gowned up and got protected. There were people getting sick. And then as you get a normal process of people having attrition, replacing them became a challenge because who wants to start working in a hospital where they're having COVID? So they have made it a challenge to replace people on the normal attrition. And then we end up short with other types of workers as well, because it's the same problem. You had to prove that you were either vaccinated or you got tested within 72 hours. And for those who weren't vaccinated, that means going to get a test every 3 days. And that's a tough thing. So here we are, short of 2,200 people.
And so what do you guys even do in a situation? Because I would imagine that has a major impact on the patient experience for patients, for employees as well. What kind of discussions are you guys having to?
How do you have enough money to pay the bonuses for people who work overtime? We were billing a lot of money because the hospital was jam-packed with people. We built a couple Quonset huts to COVID patients to keep them out of the main wings of the hospital. But we needed that space because we were overflowing with humans everywhere. So now that's all gone, and we're running, I would say 3% of our census is now COVID. That's not the issue. It's the rehiring of people and making it sound like this is a good place to work. And it's coming back, but it's a long process.
No, but Rick, I would say this is the real stuff that doesn't often get talked about. I think like in healthcare, sometimes you want to talk about the shiny things and digital health and all these other things, but they certainly have impacts, right? But I mean, if you're running a hospital and you're talking about the patient experience, you probably care a lot about hiring, like making sure you have good employees. And that's a big challenge. It's not a downer. It's a real challenge. And I think a lot of places are probably trying to wade through right now. Do you have a plan in place for overcoming it? Is this just one of those things that almost sometimes like when you're a parent and you're in it, it's like time heals all things in some ways. How are you guys overcoming that challenge?
It's a very interesting phenomena, and I have to take part of the credit for it because it was really my idea. I said, we have some money that we've had in funds that have been donated over the years. And I said, why don't we start buying things that employees had asked for before that we were turning down? We ought to make sure that the environment for them to work in is a place they want to go to. So everything they've asked for I'm on the allocations committee, which is we buy things that aren't in budget. So we're purposely allowing almost everything that's being asked for to be paid for. So in the children's hospital, we have something called the Joe DiMaggio Children's Hospital. Everything they want, but toys, entertainment, whatever's going to make and we're thinking of the employees now. We're not doing this for patient care. We're saying, how are we going to make sure the environment for our employees is one where because we're going to ask them to continue to work hard to make up for the shortage. It's a good environment. So that's our plan right now that we get back up to full employment.
Yeah. And so what are some of the things that are because it's true. I think you're right. Like you can't take care of patients unless you're taking care of your employees. Right. And because
I'll give you an example. So there's something called hospital-borne infections.
Yeah.
So we said we're going to have a concerted effort to identify the sources by looking at our statistics. Even if we do it manually, if we don't have a tool, let's find out what's actually causing them so our nurses aren't exposed to people who get infections, because it's really a bummer. Yeah. When you go to take a catheter out or change it, you see the patient's got an infection. Now they're seriously ill. And you feel like as a caregiver, it's partially your fault. How did I let this guy get like this? What did I do wrong? And it's not always them. So sometimes it's the doctor who put the catheter in. The technique is proper. So we had a concerted effort to tell them we're going to find kind of the causes of all these hospital-borne infections and take it down to zero to make you safer. We point everything to you, the caregiver, not the doctors, the nurses specifically. So they made that made them feel really good, like they're looking out for my benefit. They meaning the administration.
Yeah.
So that's an example of it. And quite a few projects like this we're doing now.
That's awesome. And so is this for this health system in particular, is this sort of one of the big pushes for this year and into next year as well, to identify those things and put a plan in place and, take action on it?
Yeah. It's this year, meaning 21 into 22. That's the 22 employees is right now. This is the end of 21. So it definitely goes into next year.
Yeah. That's awesome. This is good. So aside from hiring, what other challenges are you seeing in healthcare that are obviously ripe for improvement or that you guys are facing as it relates to patients?
So I'm sure you're familiar with Epic, and I happen to Epic as a software product, but it's not the easiest thing for interoperability as they come out with different versions every so often. So like version 16 doesn't talk to 14. And when you add to that, the fact that we've got a radiology system, a RIS, it's called Radiology Information System, that's not part of Epic. We have an ED system. We have a cardiac catheterization. We've got 8 cath labs in one hospital, and their clinical information doesn't go into Epic. And so interoperability, while we talk about it, is a reality. It's a problem.
Yeah.
And I know a lot of companies are working on some kind of software integration, but we as the health system are loath to take in other vendors because we've got a big investment in Epic, and we look to them to make these things better. And they said, we got a lot to do. We're making cardiology better. Look at how great the vertical is in cardiology, all the things you can do in it. And then you say, what about the social determinants of health? That's become a big additional source of issue. And now you have something called the ROSE. I think it's the ROSE module to be able to put that in, but you have to have Epic 20, I think, to get it. And if you have Epic 16, you can't put it in. So it's a continuing challenge. Epic was built on MUMPS. If you know what MUMPS is, it's like a software program from the early 2000s, and they don't have a real data warehouse. And so there are challenges, even though I think Cerner's pretty good too. Well, I know a lot more about Epic, but another example is being involved with medical school at the University of Miami, which is Jackson Memorial Hospital and UHealth. We are 2 different hospital systems where you have our residents trained. UHealth is on Epic, and Jackson Memorial Hospital, which is Sylvester Cancer Center, among other things, is on Cerner. So all of our doctors live in health, and they have to log into both systems and they see the same patient at Sylvester when he goes over to UHealth for a PET scan, and the results come over, and where do I look to find it? And I forgot how to get in there. And it's sad, but it's true. They're pilots. They don't talk to each other.
It's funny because it's like, I feel like, guys, going back to my days, this is part 5, 6, 7 years ago, that was talking about interoperability and making these changes. Are there things you guys can do to alleviate those issues, or is it really on the vendors to change their behavior in some ways?
I don't know who's responsible, but I can tell you I was teaching a graduate program at Miami in Masters in Health Administration. And all the students in the course I was teaching, which was entrepreneurship, want to start a business. So I had these 2 kids that wanted to build a process interface health records, and they called it ProView. They actually took Epic and Cerner and built one view and laid it on top. So when a doctor logs in, doesn't matter where they are, whether they're in Jackson or UHealth, everything is assembled using NLP or machine learning or AI in the one view. So they love that. I don't know if these kids are going to take it across the country, but it solves the interoperability problem in a very elegant way because you have one screen, and it's just kind of what Dr. Joe.
And that's kind of what the doctors want, right? Too, because it's like they just want one place to go find the information they need,
right,
as opposed to that's fascinating. Yeah. So tell me more about the work you're doing at University of Miami. It sounds great too. Like you're mentoring and teaching a whole new generation of entrepreneurs and kids who are building maybe businesses. Is it healthcare focused, or is it more sort of general business stuff that you're doing down there?
The course I taught in the undergraduate school was general entrepreneurship 101, how to start a business. So it wasn't healthcare centered, but I also support Masters of Health Administration program, which is all healthcare. And I lecture for 2 teachers. I'm a guest lecturer for them. And that's how this whole thing got started with SwiftSync. While I was doing that, I was contacted by the tech transfer office saying, we need someone who understands business and healthcare because we have one of our doctors who's developed a catheter that's really unique. And we think it would make a great company. Would you help us with that tech transfer to get it into a company? So I met with the doctors, saw the product, and they said, wow, I can't believe in this day and age that bypass surgery has come so far. And yet the one aspect that he's fixing is so arcane I never knew existed. I'm sure when I tell you this story, Jim, you'll be shocked.
Yeah.
So when you crack open the chest and you repair the valves or the vessels of the heart, you stop the heart. You probably knew that. You connect it to a pump so the blood can circulate while you fix this heart that's stable now. It's not moving. What you have to do is you attach a lead wire to the outside wall of the heart with 2 sutures, because after you're finished and you close up, the heart won't start by itself. It's like a dead battery. You got to jump start.
Yeah.
So you got this wire attached to the outside wall of the heart, and you bring that out of the chest through a little tiny hole, this little wire connected up to a pulse generator, close up the chest, plug it in, turn it on, and you start beating. And you leave that in there for 3 days while they're in recovery. And then you turn it off and the patient's heart's working now. You don't need that thing. So what do you think they do to get it out?
Open it back up and
no,
open it
they
back
don't
up.
open that chesting. They pull it out.
They just pull it out.
They yank it out of that little hole. Neil Armstrong, remember the astronaut?
Yeah, of course.
He died from that procedure.
From that procedure. Okay.
Yeah, they yanked it out and he bled out.
Oh, okay.
Yeah. So that's for something that's being done every day. That's the way they do it. So this doctor, he's an interventional cardiologist, said, I don't know why I can't put a catheter in the jugular vein into the right side of the heart and put a pacing catheter inside the heart, pace him. And he said, I'll put a little spring in there so the lead wires touch the wall of the heart. And then when I'm done, I can collapse it and pull it out of the vein.
Yeah.
Out of the wall of the chest. And so sutures.
And so he invented this sort of medical device for this procedure. That's amazing.
Exactly. Want to be able to market this or get it across the country because it's needed. What do I do, coach? So I'm brought in and I said, we got to make it into a company. We got to raise capital because you're going to need money for the clinical trials to get through the FDA approval. So I went out and about 3 weeks raised $3.5 million, started the company. I'm the CEO. I said, I'll be the CEO. You're the medical director. We have this research guy who's going to run the trials. And I got an admin person. So that's it. That's the company.
That's amazing.
And now we just finished our animal studies in sheep, put in catheters. They worked fine. And January the 16th, we're going to Paraguay.
Okay.
Because we have one of the cardiologists left the program and he's now in Paraguay. And he said, I'll do your trials. We don't need to go through an IRB and the FDA will take our data and we'll get it done in a short amount of time.
Nice.
We're doing patients on January 16th. We're putting 30 catheters in the 30 patients to make sure it works.
That's awesome. And so then the hope is FDA will take that research and it'll get approved and you can begin to sell it to hospitals and cardiac surgeons who would need it.
Actually, that brings up the next point because I said, this is not my living. It's not where I want to be at my age. I've started a company, going to market, that whole process. If you agree to, I'll do this. If you agree to let me sell the company to Medtronic or Biotronics or Boston Scientific, somebody, one of the big vendors.
Yeah.
And you get money and you're done.
Yeah.
They said, because you're not going to do this the rest of your life. You're a teacher here. You're teaching medical school.
Yeah. It's almost like
I'm doing something else. I'm not going to be a business guy the rest of my life. I'm 75 years old. I was doing this till I'm 100. No. Anyway, they said yes. So we're gonna market it to one of the big guys.
Yeah. No, that's awesome. It's funny because where I go in my head is, I don't know, I have this thought sometimes where I wonder, if you think about 100, 200 years ago, like medical procedures, and sometimes we look back on some of them and we're like, oh my God, that was so, like, how could they do that to patients? And I sometimes wonder if in 100 or 200 years, what about modern medicine now will they look back on and have that same thought, like people in the future? It's how they do that surgery now is probably one of those things, like ripping the out of the hole feels like one of those things that they would look back on and think, gosh, that is brutal. How could they have done that to patients?
Well, that brings up the whole technology of artificial intelligence, if you know what that is.
Sure. Yeah. Yep.
Repeatable patterns that can write software code and then give you direction or instruction of where to go next.
Yeah.
So you think of the ER experience and when a patient presents and there's a lot of data there, yet you go through a slow process of diagnosing and then treating. And how many times we don't know this because we as the public don't really sit in the ER, but they get it wrong sometimes.
Yeah.
Because they're seeing limited information in a short window and they got to act. Wouldn't it be nice if we knew what was going on and the software said it's either A, B, or C? And the probabilities are here. Go. That would be, and that's doable.
I would think with the amount of data that's being generated on symptoms and diseases, and there's a lot of medical literature and things like that, there's a lot of data available to be able to do that as a useful tool. And I always think about that too, like AI as a tool is not going to ever replace doctors, but it is a tool that will help them do their job significantly better if used properly.
Yeah. And bring me the information I need to know so I can focus and make the right choice instead of having me read everything.
Or know everything. You can't possibly know know everything. Yeah. Are there areas of healthcare that you're looking at right now? AI is certainly a good one. Digital health is another, but I'm just kind of curious, what are you looking at right now out there that shows promise or that you're excited about for its promise for patients?
Well, I think interoperability, AI has the potential of fixing that problem. When you have enough data, and we certainly have enough data and you have enough history, and you can even extend that to the patient in the home because you make those kind of clinical decisions on your own a lot. What do I do? Do I call the doctor? Is this a problem? I don't know. Now think about all the data that's on your watch or it's available to you on the internet that you can combine with your own symptoms and biological data and say, now all of a sudden I'm feeling different than I felt yesterday. What's your problem? I'm having palpitations. How long have you had them? Where do they originate? So you go through this whole thing. It says, no, stay home. You're fine. Or call your cardiologist and make an appointment. It's not urgent, but you should get looked at. Yeah, having that kind of guidance for patients in their home would be, I think, a great thing to have.
I think like navigating. Yeah, because it's funny, like thinking about as a patient, sort of navigating the entryway into the health system, where so much of it is right now, you're just relying on Google. You're just like typing some stuff into Google. And really, it's like the way that Google works is it's just surfacing like the stuff that might actually just be good at like gaming Google for like high search results, not like actual useful information for a patient that would be like, actually, you should go in immediately and don't go to an urgent care, go to the ER. You might want to go here pronto. And so I think having a more reliable way to navigate and figure out the urgency of care that you would need, that feels like something that patients would greatly benefit from. I know I once, as a parent with two kids, where I'm like, how serious do I need to take this thing that they might have? And I feel like I'm just constantly juggling that calculus in my head on behalf of my kids. And that's scary when it's not my life. It's like someone else's at hand.
So Medicare, give them credit. They're aware that there's a better way to do things. 5 years ago, they wanted to stimulate the use of people, care navigators, they call them, to call patients in the home who are chronically ill.
Yeah.
The idea was that if we can get people to talk to patients while they're home, maybe we can keep them out of the hospital and only go there when it's necessary. We send them to the doctor instead. Let's call that chronic care management, and we'll come up with a code and pay $42 a month per patient for someone to do that.
Yeah.
So I started a company to do that and quickly found out that for $42 a month, if we have to manually read a patient's record and then call them and you have to talk to them for 20 minutes per patient per month, you can't make money because the labor costs are too high. So we built software to automate the ingestion of clinical information from a patient's chart. So we build interfaces into that customer who's a doctor with a lot of patients. We build it, we interface into Epic, Cerner, Athena, Allscripts, suck in all the information per patient. And from that, we use the AI to create a script based on that patient's condition.
Yeah.
That we get to these navigators and we tee up the whole thing. So the navigator gets up in the morning, they open up their computer, it has a list of all the patients they're going to call, what the conditions are, and they're all summarized and highlighted, what drugs they're on, what symptoms they've had. Here are the questions to ask. If they give these answers, we want you to call their doctor and say your patient's called in and they're having this problem. So it's all semi-automated, even though a human now is in the loop between the patient and the data. The patient feels like they're getting this great concierge service. Like, how'd you know that about me? How'd you know that I've got 3 kids and my cardiologist is Dr. Jones? How'd you know that?
Yeah.
The patients relate to it. We have a 90% rate of continuation. Only 8% of the patients drop after 6 months of these calls. They love it.
Well,
and we know we've increased patient visits by 18% per office.
Yeah.
And these are patients that need the visit. These aren't the ones that are worried. They make appointments for people who we're going downhill. We see your hemoglobin A1C is now over 7 and it was 6 before that and 5 before that. We think you should see your doctor, and I'm going to call him and tell him you're coming in. When would you like to go? So we make sure they get in there for that visit, not the hospital, but to the doctor. And that's a way of shortcutting the whole thing we were just talking about with software.
I feel like that should be the norm, right? That should be how like
Yeah.
Technology works, right? Like you want, but the reality is like most medical practices are like, they don't have the resources to be able to have someone sift through all that data to build, like it has to almost be an automated process at this point to be able to do that. Because manually doing it, you'd never be able to do that in an effective way.
So in January of 2022, 2 months from now,
Yeah.
Medicare is raising the reimbursement rate from $42 a month to $63.
Okay.
They have seen the light and they really want this program to be done everywhere. So they're putting money in it.
$63, would that make a difference versus the 42?
Yeah, we figured that at $42, you have to do 200 patients per navigator per month.
Okay.
Can't do that without software.
No.
If they raise the rate to 63, you could do 125 patients. So there'll be a lot more people doing it without having to build the software to automate and make it more efficient. You can make money. The bottom line is you want more patients to have the benefits. So it doesn't always have to be with automation. As long as you pay enough money, you can get it done now.
Yeah, but the automation probably makes the margins a little bit
for sure.
better, I would
For
think.
us.
You can get more
For us,
patients
it's a
in the
win.
door.
Yeah. We'll be able to, wow, it's a big deal for us, but I just, for the country and the service and the value of having people interceded on their behalf before things get bad is just a healthier way to live.
It is, right? Because it's the challenge is if you're reactive by the time you get into the healthcare system, that's really hard. That's where a lot of the costs come from when we're dealing with comorbidities or chronic diseases that you're constantly juggling versus preventive medicine.
Sure.
Yeah, that's fascinating. So what other areas are you looking at for AI care management? That's a great one. I wouldn't even consider that. But are there other areas where you're looking at within a health system where you think that technology can be applied to just better serve health systems and patients and the like?
I think for patients, there's a whole big future there. But I find as an entrepreneur, focus is the biggest challenge. If you don't focus on one or two areas, you lose the ability to perform at a high level because you really have to become an expert in what you do. So I don't pick too many projects. So I've got two right now, the catheter and this chronic disease management thing, which I now have a company to do it. I don't have to do it every day like I was. So I just thought I'm only called in to talk to the bigger health systems and understand how to make the workflow happen. It's all about workflow for them. And where does this fit in with what they have right now? But I think the biggest area that I'm not involved in that I would love to be involved in if I had the time is the whole idea of value-based care.
Yeah.
Because it needs technology. Without it, it's not going to work because the current systems are all built for fee-for-service, not for based care.
So, I mean, you talk about like interoperability challenges within just one health system. So now if you've got like ACO contracts where multiple health systems are partnering up and in joint agreements and things like that. And now you're talking about, it's like a full nightmare for those interoperability challenges. I don't even honestly imagine how they are effectively doing joint agreements without some sort of operability or better technology in place to better support those patients. I mean,
it's hard. If you've owned a bunch of the doctors, which most health systems do, you don't own all of them. You have a lot of admissions coming from affiliated physicians who aren't owned. And they have their own EHRs in their offices because we don't own them. Now they have their own data. So they get it. The patients will get admitted, sure, but we won't have the benefit of all that history because we can't see the EHR.
Right.
It's in the doctor's practice. It's not interfaced. So that means I'm going to spend more money on a value-based contract on like a patient with heart failure. I don't know what medications he's on. He's coming in here. He's in failure. He's hard to communicate with. And I don't know if he's been on a beta blocker or not, but his heart rate's at 55. And if I give him a beta blocker now, it'll drop him down to 40 and his blood pressure will fall down. So it's a real challenge. How do you optimally take care of those people and knowing you're not getting any more money because it's on a value-based contract, you're trying to do it with a fixed cost.
Yeah.
So you can share the upside. If I had more time, that would be the next place I'd go because we did it with DRGs. Believe it or not, we came up with a value-based care system called Medicare.
Yeah.
For hospitals called DRGs. It happened.
Yeah.
We never thought we'd get, but we did. So eventually I think we will have a different paying mechanism like Medicare Advantage for private pay as well.
Yeah. And I think like Maryland has shown promise with their global cap. They've got like a global cap system in Maryland where
they've had it for a lot of years.
For several years. And that actually, as far as like reducing the cost for patients, has, I think, proven pretty perspective. I'm not a policy wonk, so I'm not going to pretend to just make stuff up off the top of my head. But I was reading an article recently that said that they've had like really good like procedures in New York that are like $1,800. Maryland is it's like 300 comparatively as a result of their sort of cap system. But yeah, something's got to give. It's hard for patients when, you're paying premiums on your high deductible plan, you go, and then you're still paying out of pocket because, you're high deductible. You're not necessarily like getting a whole lot more of that until you meet the deductible. It's hard for the average patient trying to stay healthy and stay out of harm's way. So Rick, thank you so much. I want one last question for you. Where do you go to learn new ideas and keep a fresh perspective on things? Obviously, I would imagine being around students is probably a good source of inspiration. I know when I'm around young kids, I'm like, man, I am not cool anymore. But I'm curious for you, like where do you go to learn and get ideas and figure out like where you want to swim to next?
So I'm not a voracious reader, but I do read the Wall Street Journal every day and the New England Journal of Medicine every week.
Yeah.
And I've been doing both for I don't know how many years. A lot of years. The New England Journal is an interesting vehicle because the editorials more than the articles are more up to date, and you learn a lot from those editorials in the back.
Yes. So you read, you read like all the actual physical. Yeah. Okay. Nice.
And they're very informative and straight from the heart. They're not always factually true.
Sure.
Or accurate. But you take what you can get. It's good reading. And I get a lot from being involved with the hospital.
Yeah.
Because you hear all kinds of problems that you otherwise wouldn't be exposed to.
Yeah. And your mind naturally, it feels like you are think about the world as far as in terms of solving problems. I don't know if that's entirely true, but it feels that way just based on your career and history, that feels like you've attacked and solved one problem after another.
That your observation's accurate about me. I don't do anything unless it's solving a problem. I don't create candy or toys. I always try and solve a problem because in healthcare, I'll never get done.
No,
but I'll make a headway.
That's awesome. All right, Rick, thanks so much for joining the show. This has been a wonderful conversation. I'm really just tickled that you made the time to join us. And so I thank you from the bottom of my heart. It was a pleasure.
Sorry, I couldn't follow the script the whole way, but it was fun talking.
Oh my God, no, this is great. I'm so glad we took a left turn from the get-go and did our own thing. So I appreciate it.
Okay.
All right. Take care.
Mm-hmm.